Hello, I'm Mark Shatner, one of the advanced endoscopists at Memorial Sloan Kettering Cancer Center.
And my name is Govindarajan Srimathveeravalli. I'm a biomedical engineering faculty in the Department of Radiology.
And we're here to discuss our manuscript, Transmural Ablation of the Normal Porcine Common Bile Duct with Catheter-Directed Irreversible Electroporation is feasible and does not impact duct patency, which was recently accepted for publication in GIE. Endoscopic or percutaneous focal ablation has been piloted for relieving stent ingrowth and for debulking biliary tract tumors with the goal of increasing the duration of ductal patency. However, the existing technology has limited efficacy and the potential risk of treatment-related complications which have impeded broader clinical applications. Given the clear clinical need for better ablation techniques for use in the biliary tree, we decided to develop devices and technologies for this indication.
Irreversible electroporation is a relatively new technique that has been used for soft tissue ablation in liver, pancreas, and other organs. Percutaneous IRE of peribiliary tumors in patients has been reported to be safe, and likewise, IRE of the normal swine bile duct did not result in perforation or stricture formation. These features make IRE an attractive candidate for endoscopic ablation of tumors in the bile duct. Therefore, the purpose of our study was to evaluate the feasibility, reproducibility, and early safety of endoscopic ablation of the normal porcine common bile duct with IRE using a novel catheter-mounted electrode. To do this, we constructed a prototype catheter device in-house by modifying a balloon dilation catheter to serve as a monopolar device. This is the catheter that we modified, and the catheter tip has an electrode that's right over here with an active surface that's approximately 20 millimeters long and can be used with a distally placed grounding pad for the ablation of the bile duct.
We tested the device in 6 female Yorkshire pigs. The animals were sedated and placed under general anesthesia, and a duodenoscope was used to place the ablation catheter within the duct. A grounding pad was placed on the flank of the animal, and all ablations were performed with a single set of experimental treatment parameters of 90 pulses delivered at 2,000 volts. 1 or 2 ablations were performed in each animal, and 4 animals with 2 ablations were sacrificed at day 1 after treatment, and 2 animals with 1 ablation each were recovered and then observed for 7 days. The animals were assessed with immediate post-treatment cholangiography and CT imaging prior to sacrifice. Histopathology was used to determine the penetration and reproducibility of ablation from animals sacrificed at day 1 after treatment. Tissue samples from animals sacrificed at day 7 after treatment was used to determine the safety of the technique. The procedure was simple to perform and was completed successfully in all animals without any interruption or intra-procedural adverse events. Immediate post-ablation cholangiography demonstrated the absence of any treatment-related perforation, and all animals survived to the designated endpoint. CT imaging prior to any sacrifice did not reveal any signs of inflammation, ductal dilation, or biliary leakage.
Gross and histopathology examination revealed clearly demarcated lesions that approximated the size of the electrode mounted on the catheter. Transmural ablation was achieved in 7 of 8 lesions in the day 1 samples. From the day 7 samples, we observed some signs of inflammation, thickening of the ductal wall, and diffuse fibrosis, but ducts in both animals appeared otherwise patent. Remarkably, regeneration of the epithelium and recovery of the mucosa could be observed in treated tissues at day 7 post-treatment.
Ablation with current systems such as RFA or photodynamic therapy prior to biliary stenting has been shown to increase the duration of patency and is also used to control tumor invasion into the stent. Despite such benefits, aggressive application of ablation for deeper tumor treatment has a significant risk profile. This may be largely from the thermal mechanism of existing ablation techniques such as RFA or PDT.
In comparison, sub-millisecond long electric pulses are used to alter the transmembrane potential of cells during IRE, which induces pore formation in the cell membrane and leads to cell death. Relatively little energy is delivered during IRE, and tissue heating during the treatment is therefore negligible. These features of IRE aid the sparing of the extracellular matrix from ablation effects, allowing penetrative ablation of the biliary tract with reduced risk of complications.
There are of course some questions that were not adequately answered with this study. For example, large animal models of cholangiocarcinoma do not readily exist, and therefore we do not know the efficacy of IRE when treating tumors. However, our results provide a rationale for evaluation of efficacy and durability of this technique in future patient studies. Looking ahead, IRE for biliary ablation may be the most relevant for tumor debulking prior to stenting and for treating tumor ingrowth in stents without affecting the patency of normal bile ducts.
Thank you for watching this video. You can direct questions regarding this research to either myself or Dr. Shatner.
Thank you.